shape, appearance, or location. Judging by its location, the radiologist reports it as a simple pericardial cyst or spring water cyst. Which of the following statements concerning congenital simple pericardial cysts is false? A. They are homogeneous and well-defined on frontal chest X-ray. B. They are most commonly left-sided. C. On MRI, they are low on T1W and high on T2W images. D. Pericardial cysts can contain proteinaceous material. E. Pericardial cysts can occasionally calcify. 68. A 90-year-old man is admitted following intermittent episodes of bright red rectal bleeding. He is hemodynamically stable on initial assessment. OGD and flexible colonoscopy are normal. He subsequently has another bleed on the surgical ward and is then referred for a CT mesenteric angiogram. Which of the following statements is false regarding CT mesenteric angiography? A. Severe bleeding episodes, such as those manifesting with hemodynamic instability, decrease the pretest probability of a positive result for active bleeding at CT angiography. B. Active bleeding must be present during the time contrast is injected into the vascular system in order to demonstrate the site of bleeding. C. Portal venous phase imaging depicts extravascular blushes with higher sensitivity. Sensitivity than arterial phase imaging does. D. Retention of previously administered barium in colonic diverticula may be mistaken for, or may obscure, acute extravasation of contrast material. E. Hyperattenuating material within the bowel lumen on the unenhanced scan without additional findings in the contrast-enhanced phases indicates recent hemorrhage. Soft tissue densities and are most commonly found at the right pericardiophrenetic angle. Pericardial cysts are visualized most easily using CT or MRI. With MRI, simple pericardial cysts are characterized by low signal intensity on T1 weighted images or high signal intensity on T2 weighted images. With CT, pericardial cysts are usually of water density, but when they contain sufficient proteinaceous material, the attenuation may be greater than that of water. Occasionally, pericardial cysts may calcify and simulate thymic cysts. Kissler T. ETAL Multimodality Imaging of the Pericardium, 2007 Update. Contempt Dian Radiol. 2007, 30, 1916. 68. A. Severe bleeding episodes, such as those manifesting with hemodynamic instability, decrease the pretest probability of a positive result for active bleeding at CT angiography. Severe bleeding episodes, such as those manifesting with hemodynamic instability, increase the pretest probability of a positive result for active bleeding at CT angiography. Artigas JM, ETAL Multidetector CT Angiography for Acute Gastrointestinal Bleeding, Technique and Findings. Radiographics. Hemorrhage. 69, a 25-year-old man undergoing abdominal CT shows the presence of bridging renal tissue across the midline at the level of the lower poles, consistent with a horseshoe kidney. All the following are recognized associations, except A. Bicornuate uterus. B. Cardiac anomaly. Chapter 1. Test paper 1, questions. 13. C. Undescended testis. D. Tracheoesophageal fistula. E. Anorectal malformation. 7. Radiographics. 2013, 33:14, 53:70. 69. D. Tracheoesophageal fistula. Horseshoe kidney is the most common fusion anomaly of the kidneys. There is recognized association with cardiovascular, skeletal, CNS, genitourinary anomalies, undescended testes, bicornuate uterus, duplication of ureter, hypospadias, etc., anorectal malformations, trisomy 18, and Turner syndrome. Vesicoureteric reflux, hydronephrosis secondary to PUJ obstruction, and increased frequency of complications like renal stones and infection are recognized. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott, Williams, and Wilkins. 70. A young patient is followed up for a fractured tibia at the outpatient clinic. A repeat radiograph is acquired, which shows abnormal healing and callus formation at the fracture site. All the following are possible causes, except A. Cushing syndrome. B. Osteogenesis imperfecta. C. Osteopoikilosis. D. Paralytic state. E. Asthmatic on steroids. Wilkins, 2011:948. 70. C. Osteopoikilosis. Patients with comorbidities like diabetes, anemia, and malnutrition can suffer from impaired bone fracture healing. Drug therapy like corticosteroids and NSAIDs can also produce similar problems. Osteogenesis imperfecta is a connective tissue disorder with resultant abnormal bone density and structure, resulting in poor mineralization and fragile, brittle bones. Osteopoikilosis is a benign condition and usually found incidentally. It is a form of sclerosing bone dysplasia with multiple enostoses. It is not associated with impaired fracture healing. Sim E. Osteopoikilosis and fracture healing. Unfall chirurgy. 1989, 15, 63035. 71. B. 71. A 67-year-old man has been rushed to the stroke unit with features of acute stroke. All of the following are true about acute stroke imaging, except A. CT source images correlate with infarct volume. B. Matched CBV, cerebral blood volume, and CBF, cerebral blood flow, represent salvageable brain. C. Diffusion-weighted MR imaging assesses the infarct core. D. Mismatch between PWI, perfusion-weighted imaging, and DWI, diffusion-weighted imaging, volumes represent salvageable brain. E. T2 shine through is seen as bright on DWI. B. Matched CBV, cerebral blood volume, and CBF, cerebral blood flow, represent salvageable brain. An important advance in stroke imaging is the development of CT perfusion imaging. CT angiography source images, CT-ASI, represent cerebral blood volume that is reduced in the core infarct and correlates with infarct volume as seen on DWI, diffusion-weighted imaging. CBF, cerebral blood flow, CBV, cerebral blood volume, and MTT, mean transit time, are three parameters that can distinguish infarcted tissue from potentially salvageable penumbra. Ischemic but non-infarcted tissue will have decreased CBF, elevated MTT, and normal or high CBV mismatch. Once infarcted, there will also be a persistent decrease in CBV match defect. Sensitivity and specificity of DWI for stroke detection is very high. DWI bright signals do not necessarily represent irreversibly infarcted tissue, but reflect redistribution of water from the extracellular to the intracellular space in ischemic tissue. It is necessary to analyze maps of ADC. ADC, apparent diffusion coefficient, to distinguish the effects of reduced water diffusibility, dark on ADC, from T2, shine through bright on ADC. Both features lead to the DWI bright signal seen. Chapter 2. Test. In ischemia, the volumetric mismatch between the PWI and DWI volumes is a marker of potentially salvageable tissue at risk. Overall DWI provides the best estimate of infarcted core. SA de Camargo EC. EC, Corochet's WJ. Neuroimaging of ischemia and infarction. NeuroRx. 2005, 222. 72, neck US of a previously well 2-year-old girl shows a 3 cm thin-walled cystic structure. Structure with multiple septae of variable thickness in the left posterior triangle with extension into the mediastinum. The diagnosis is A. Third branchial cleft Cyst B. Cervical meningocele C. Cystic teratoma D. Lymphangioma E. Second branchial cleft Cyst. 73, a 34-year-old woman with chest pain, shortness of breath and collapse is brought to the A&E department. Initial chest X-ray is abnormal. Subject to the abnormal appearance of the cardiac contour, an MRI is obtained in the local cardiac center on the following day, which confirms a large congenital pericardial defect. All of the following are imaging features except A. Abnormal cardiac contour on plain chest X-ray. B. Failure to identify pericardium on CT or MR is diagnostic. C. Most commonly, a left-sided location. D. Shift of cardiac axis to the left. E. Association with ASD. 7. Portion of the lesion. Prenatal US may demonstrate a cystic hygroma in the posterior neck soft tissues. On CT images, cystic hygromas tend to appear as poorly circumscribed, multiloculated, hypoattenuated masses. Masses. They typically have characteristic homogeneous fluid attenuation. Usually, the mass is centered in the posterior triangle or in the submandibular space. A third branchial cleft cyst most commonly appears as a unilocular cystic mass centered in the posterior cervical space on CT and MRI. At US, a second branchial cleft cyst is seen as a sharply marginate, round to ovoid, centrally anechoic mass with a thin peripheral wall that displaces the surrounding soft tissues. The classic location of these cysts is at the anteromedial border of the sternocleidomastoid muscle. The first branchial cleft cyst appears as a cystic mass either within, superficial to, or deep to the parotid gland. Kolar KK, ETAL congenital cystic masses of the neck, radiologic pathologic correlation. Radiographics. 1999, 19, 112146. 73, B. Failure to identify pericardium on CT or MR is diagnostic. Congenital pericardial defects are uncommon. They range from small defects to complete absence of the pericardium. Both small pericardial defects and complete absence of the pericardium most often are left-sided. They can be recognized on plain chest radiographs because there is abnormal cardiac contour due to protrusion of all or part of the cardiac chamber, for example, the left atrial appendage, through the defect. Shift of the cardiac axis to the left and posteriorly is seen, with complete absence or large pericardial defects. With CT or MRI, failure to visualize a portion of the pericardium does not necessarily indicate a pericardial defect, however, because the pericardium over the left atrium and ventricle may not always be visualized in normal subjects. Patients with pericardial defects also may have one or more associated congenital abnormalities, including atrial septal defect, patent ductus arteriosus, mitral valve stenosis, or TOF, which also are detectable on CT or MRI. Kissler T, ETAL multimodality imaging of the pericardium, 2007 update. Contempt Dian Radiol. 2007, 30, 1916. Wang ZJ, ETAL CT, and MR imaging of pericardial disease. Radiographics. 74, a 5-year-old boy involved in an RTA is referred for a trauma CT scan. The reporting radiologist does not find any acute abnormality. However, there are other incidental findings on the scan suggestive of malrotation. Which of the following options is the most specific feature of gut malrotation on CT? A. SMV, superior mesenteric vein, anterior to the SMA, superior mesenteric artery. B. SMV to the right of the SMAC, whorl sign around the SMAD. DJ, duodenojejunal, flexure to the right of the midline. E. SMV to the left of the SMA. Radiographics. 2003, 23, S16780. 74, E. SMV to the left of the SMA. SMV position to the left of SMA is the most specific sign of malrotation on CT, 80%. Other signs on CT include the whorl sign around the SMA and large intestine on the left with small intestine on the right. Abnormal position of the cecum and duodenum with duodenojejunal junction over the right pedicle is the most specific sign of malrotation on barium meal studies. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011:86970. 75, D. Tuberous sclerosis, TS. 75, a 17-year-old girl is brought to the emergency department with sudden onset abdominal pain. She is known to have a cardiac tumor. On examination, she is hypotensive, peritonitic, and undergoes an urgent CT abdomen and pelvis. This shows bilateral large renal masses. The largest on the right measures 12 centimeters with multiple low attenuation areas of 20 with large tortuous vessels and contrast extravasation into the retroperitoneum. These features are associated with A. Von Hippel-Lindau B. Neurofibromatosis type 1C, Sturge-Weber syndrome D. Tuberous sclerosis E. Amyloidosis. 76, a young woman presents to the AED following a scuffle on a night out. TS is an autosomal, dominant, inherited neurocutaneous syndrome characterized by a variety of hemorrhagic lesions in various organs. Classically, TS demonstrates. Chapter 2. Test paper 1, answers. A triad of clinical features, Vogt triad mental retardation, epilepsy, and adenoma sebaceum. Recently advocated criteria for diagnosis of TS consist of both major and minor diagnostic features. Major features include facial angiofibromas, hypomelanotic macules, cortical tubers and subependymal nodules, frequent, retinal hamartoma, lymphangioliomyomatosis, renal AML, angiomyelopoma, and cardiac rhabdomyomas common, and shade green patches, ungual fibroma, and subependymal giant cell tumors uncommon. Minor features include dental enamel pits and hamartomatous polyps, frequent, bone cysts, renal cysts, gingival fibromas and cerebral white matter radial migration lines common, and confetti skin lesions and retinal achromatic patches uncommon. Definite diagnosis requires 2 major, or 1 major, and 2 minor criteria. Omioka S. ETAL Pictorial Review of Tuberous Sclerosis in Various Organs. Radiographics. 2008, 28, 7E32. Out. On examination, there is a suspected fifth metacarpal fracture of her right hand. A plain radiograph is subsequently organized. This does not demonstrate a fracture, but it is noted that the patient has relatively short fourth metacarpal bones. Old chest films show bilateral inferior rib notching involving the 3rd to 6th ribs bilaterally. What is the likely diagnosis? A. Noonan syndrome. B. Turner syndrome. C. Pseudohypoparathyroidism. D. Marfan syndrome. E. Achondroplasia. 76. B. Turner syndrome. Turner syndrome is a female, sex chromosome abnormality from the deletion of one X chromosome, 45 exo. It is characterized by a webbed neck and short stature. Skeletal manifestations include short fourth metacarpals and Madelung's deformity. 5–20% of patients with Turner syndrome have coarctation of the aorta, which would account for the additional finding of rib notching. Pseudohypoparathyroidism and pseudohypoparathyroidism can exhibit a short fourth metacarpal, but they are not associated with coarctation of the aorta. Noonan syndrome is associated with short stature and characteristic facies, along with other congenital cardiopulmonary anomalies, but shortening of the fourth metacarpal is not a feature of this entity. Marfan syndrome is associated with pectus excavatum and aortic root dilatation with the increased risk of aortic dissection. Dannert W. Radiology Review Manual, 6th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2007:174. Mazzanti L. Cacciari E. Congenital heart disease in patients with Turner syndrome. J. Pediatric. 1998, 133, 56, 88, 92. 77. E. Dilatation of ventricle non-contrast CT is usually the first neuro. Neuroimaging examination performed. Achondroplasia. 77. A 66-year-old man with acute onset of right upper limb weakness was brought to A&E within an hour of the onset of symptoms. All of the following are recognized features of early ischemic change, except A. Insular ribbon sign. B. Dense MCA sign. C. Sulcal effacement. D. Obscuration of the lentiform nucleus. E. Dilatation of ventricle. 78. In order of frequency, the most common performed in acute stroke assessment. In addition to detecting hemorrhage, modern non-contrast CT can reveal early ischemic change, such as hypoattenuation of the parenchyma and gray matter with loss of gray-white differentiation, insular ribbon sign, obscuration of the lentiform nucleus, brain swelling with sulcal effacement, and compression of the ventricular system and basal cisterns, the dense artery, MCA sign, and the MCA dot sign. S.A. de Camargo E.C., Corochets W.J. Neuroimaging of ischemia and infarction. NeuroRx. 2005, 2–226576. Location of congenital lobar emphysema is as follows. A. LUL, LLL, RULB, LUL, RML, RULC, RUL, RML, LLLD, LUL, RUL. RUL, RLLE, LUL, RML, RLL, LLL left lower lobe, LUL left upper lobe, RLL right lower lobe, RML right middle lobe, RUL right upper lobe. 79. A 66-year-old woman with progressive shortness of breath, reduced exercise tolerance and occasional chest pain shows engorged neck veins and hepatomegaly on clinical examination. She is clinically thought to have constrictive pericarditis. All of the following are imaging features of constrictive pericarditis, except A. Pericardial thickness of more than 4 millimeters. B. Pericardial thickening may be limited to the right side of the heart. C. MR is better at demonstrating pericardial calcification. D. Sigmoid-shaped ventricular septum. E. Increased diameter of the IVC. Chapter 1. 76. 78. S.A. de Camargo E.C., Corochets W.J. Neuroimaging of ischemia and infarction. NeuroRx. 2005, 2-2265-76. 78. B. LUL, RML, RUL congenital lobar emphysema represents a condition of progressive overdistension of one or multiple pulmonary lobes secondary to deficiency/immaturity of bronchial cartilage, endobronchial obstruction, or extrinsic compression. It is more common in boys. Preferential involvement is LUL, left upper lobe, RML, right middle lobe, RUL, right upper lobe, 2 lobes. Initial chest X-ray shows opacification of lobe secondary to delayed clearing of pulmonary fluid. This is followed by progressive features of air trapping, hypertranslucent lung, and mediastinal shift. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott, Williams and Wilkins, 2011. 79. C. MR is better at demonstrating pericardial calcification. Patients with constrictive pericarditis present with symptoms of heart failure. The most frequent causes are cardiac surgery and radiation therapy. Other causes include infection, viral or tuberculous, connective tissue disease, uremia, neoplasm, or idiopathic condition. Chapter 2. Test paper 1, answer. Transthoracic echocardiography is not very accurate in the depiction of pericardial thickening. Transesophageal imaging allows better visualization of the pericardium, and Doppler techniques are particularly useful in the diagnosis. However, the transesophageal approach has a narrow field of view and is invasive. Both CT and MRI demonstrate the pericardium very well. Normal pericardial thickness is less than 2 mm. Pericardial thickness of 4 mm or more indicates thickening, and, when accompanied by features of heart failure, is suggestive of constrictive pericarditis. Constrictive pericarditis and restrictive cardiomyopathy are differentiated on the basis of thickened pericardium. Pericardial thickening may be limited to the right side of the heart, or an even smaller area, such as the right atrioventricular groove. An additional advantage of CT is its high sensitivity in depicting pericardial calcification. It is important to remember, however, that neither pericardial thickening nor calcification is diagnostic of constrictive pericarditis unless the patient also has symptoms of physiologic constriction or restriction. At both CT and MRI, the right ventricle tends to have a reduced volume and a narrow tubular configuration. In some patients, a sigmoid-shaped ventricular septum or prominent leftward convexity in the septum can be observed. Systemic venous dilatation, particularly inferior vena cava, IVC, hepatomegaly, and ascites also are frequently seen. Wang ZJ, ETALCT. A 60-year-old woman presents with abdominal cramps and watery diarrhea associated with flushing of the face. A CT colonography study is performed as the patient is unable to tolerate optical colonoscopy. The colon and rectum are normal, but there is ileal thickening and a 2 cm partly calcified mass in the small bowel mesentery with surrounding desmoplasia. Carcinoid is suspected. Which of the following statements is true about small bowel carcinoid tumors? A. Carcinoid syndrome has higher morbidity and mortality than the tumor itself. B. Over 60% have carcinoid syndrome. C. Carcinoid tumors are associated with neurofibromatosis type 2. D. They most commonly occur in the colon. E. They commonly cause osteolytic metastasis to bone. 81. The following are signs of a normal gestational sac. CT and MR imaging of pericardial disease. Radiographics. 2003, 23, S16780. 80. A. Carcinoid syndrome has higher morbidity and mortality than the tumor itself. Carcinoid is the most common tumor of the small bowel and appendix. 7% of small bowel carcinoids are associated with carcinoid syndrome. There is no association with NF2. Carcinoid tumors most commonly occur in the appendix, 30% 45%, and small bowel, 25% 35%. Carcinoid syndrome has higher morbidity and mortality than the tumor itself. Common sites of metastasis are liver, lungs, lymph nodes and bone, osteoblastic. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott, Williams and Sac, except A. Intradecidual sign. B. Cardiac activity seen with a CRL, crown rump length of 6 mm. C. Double decidual sign. D. Mean sac diameter increases by 1 mm/day. Day. E. Embryo seen with a mean sac diameter of 10 mm. Wilkins, 2011:826-8. 81. E. Embryo seen with a mean sac diameter of 10 mm. The gestational sac is first identifiable on transvaginal ultrasound at 4.5 weeks. It appears as a round to 3 mm fluid collection. It is located in the central echogenic part of the endometrium, decidua. In some cases, it is surrounded by two echogenic rings corresponding to the two layers of decidua, described as the double decidual sac sign of intrauterine pregnancy. Sometimes the gestational sac is eccentrically located on one side of a thin white line corresponding to the collapsed uterine cavity, called the intradecidual sign. The yolk sac is the first structure visualized on TV's transvaginal scan, within the sac at 5.5 weeks. Yolk sac is evident when sac diameter is 10 mm. Heartbeat is evident when crown rump length, CRL, is 5 mm. On TVs, an embryo is seen when the mean sac diameter is 18 mm. Mean sac diameter increases by approximately 1 mm per day. Lack of fetal pole in a gestational sac with diameter more than 20 mm is suggestive of an anembryonic or non-viable pregnancy. Adam A. E. T. A. L. Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008:1205. Daublet P.M., Ultrasound Evaluation of the First Trimester. Radio 10 mm. 82. A 17-year-old girl presents with a history of acute on-chronic burning neck pain radiating into the right shoulder and arm. There is associated palmar paresthesia, easy fatigability, and loss of power, exacerbated by elevating the arm to the shoulder level. Sagittal T1W MRI obtained with the arm in the neutral position shows ample fat surrounding the subclavian vessels and brachial plexus. With the arm in abduction, there is compression of the subclavian vessels. What is the diagnosis? Diagnosis. A. Subclavian artery stenosis. B. Parsonage-Turner syndrome. C. Median nerve entrapment. D. Thoracic outlet syndrome. E. Subclavian steal syndrome. Radial Clin North AM 2014, 52, 611-91-9. 82. D. Thoracic outlet syndrome. Thoracic outlet syndrome involves the brachial plexus and the subclavian artery or vein at three anatomic levels where they are vulnerable to entrapment: the interscalene space, the costoclavicular space, and the retropectoralis minor space. Thoracic outlet syndrome may result from post-traumatic fibrosis of the scalene muscles, compression secondary to activities like backpacking, and clavicular fractures with callus formation and exercise-related muscle hypertrophy affecting. Chapter 2. Test Paper 1, Answer. Weightlifters, swimmers, tennis players, and so on. Other causes include mass lesions such as lipomas, neurogenic tumors, accessory muscles, and fibrous bands. MRI can help identify specific muscle denervation patterns. Muscle edema may occur within 24-48 hours. In contrast, fatty atrophy reflects chronic denervation and manifests several months later. In this setting, MRI has an advantage over electromyography, which does not demonstrate signs of muscle denervation until 2-3 weeks after nerve impairment. Radiographs may reveal a cervical rib or a prominent C7 transverse process. Narrowing has been reported in the costoclavicular and retropectoralis minor spaces during imaging with postural maneuvers during dynamic MRI. Sagittal T1 weighted MRI sequences are particularly useful in demonstrating the presence of denervation-related fatty atrophy of muscles, effacement of fat planes around the compressed plexus, and an abnormal intramuscular course of the components of the brachial plexus. The retropectoralis minor space is not frequently affected by entrapment and is more often involved by mass lesions. Syndrome. 83. A 67-year-old woman is imaged 3 hours after a witnessed sudden onset of a right hemiparesis. Transverse DWI, B equals 1000 SEC/mm2, demonstrates signal change in the subcortical region, including in the lenticular nucleus and corona radiate. Which of the following statements concerning diffusion-weighted MR imaging in cerebral infarction is false? A. It measures redistribution of water to intracellular space. B. DWI can remain positive for up to 3 weeks post-infarction. C. DWI is positive as early as 30 minutes post-infarction. D. Acute infarcts show hyperintense signal on ADC. E. acute infarcts show hyperintense signal on DWI. 84. The most Linda D.D., ETAL multimodality imaging of peripheral neuropathies of the upper limb and brachial plexus. Radiographics. 2010, 30, 51373 400. 83. D. Acute infarcts show hyperintense signal on ADC. Sensitivity and specificity of DWI for stroke detection is very high. DWI bright signals do not necessarily represent irreversibly infarcted tissue, but reflect redistribution of water from the extracellular to the intracellular space in ischemic tissue. It is necessary to analyze maps of ADC to distinguish the effects of reduced water diffusibility, dark on ADC, from T2, shine through bright on ADC. Both features lead to the DWI bright signal seen in ischemia. DWI is already positive in the acute phase, as early as 30 minutes, and then becomes brighter with a maximum at 7 days. DWI in brain infarction will be positive for approximately 3 weeks after onset. ADC is of low signal intensity with a maximum at 24 hours and then increases in signal intensity and finally becomes bright in the chronic stage. S.A. de Camargo E.C., Corochet's W.J. Neuroimaging of ischemia and infarction. Most common structure to herniate in Bachdalic hernia is A. Stomach B. Spleen C. Omentum D. Left lobe of liver E. Pancreas. 85. Which of the following statements regarding the normal NeuroRx. 2005, 2-2265-76. 84. C. Omentum Bachdalic hernia represents the commonest type of congenital diaphragmatic hernia. It is more common on the left. The most common structure to herniate on the left is omental fat, on the right is the liver. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011. 85. E. Pericardium is false. A. It consists of 2 inner serous layers of tissue and 1 outer fibrous layer. B. It is visualized on lateral chest X-ray as a fat pad sign. C. It is 1-2 mm thick on CT and may contain up to 30 ml of fluid. D. It is low in signal on T1W MRI. E. On frontal chest X-ray, it is visualized as a 2 mm stripe outlined by fat. E. On frontal chest X-ray, it is visualized as a 2 mm stripe outlined by fat. The pericardium is composed of an outer layer of fibrous tissue and 2 inner layers of serous tissue. The normal pericardium is not usually seen on plain film chest radiography on the frontal projection, but it may be identified on a lateral projection as an opaque line bordered by mediastinal and subepicardial fat termed the fat pad sign. With high-resolution CT, the pericardium may be visualized as a 1 to 2 mm band of soft tissue attenuation. With T1 weighted MRI, the pericardium is a dark band bordered by high-intensity fat. The pericardial sac normally contains 15-30 ml of fluid lying between the parietal and visceral layers of the serous pericardium. The fibrous pericardium is anchored to the diaphragm by the pericardiophrenic ligament and the central tendons. The sternopericardial ligaments provide anterior attachment. The outer layer of the pericardium extends to and fuses with the root of the aorta, the right and left pulmonary arteries, the superior vena cava, and the pulmonary veins. The visceral pericardium reflects from the heart along the great vessels onto the parietal pericardium. Pericardial extensions, recesses, or sinuses are formed at these reflections. Kissler T. ETAL multimodality imaging of the pericardium, 2007 update. Contempt Dian Radiol. 86. A 50-year-old woman with long-standing abdominal pain, weight loss and poor appetite undergoes a CT abdomen and pelvis. This shows mesenteric thickening with a fine stellate pattern extending to the bowel border. The mesenteric mass does not displace the mesenteric vessel's masses and shows a fat ring sign. The most likely diagnosis is A. Retroperitoneal fibrosis B. Carcinoid C. Sclerosing mesenteritis D. Epiploic appendigitis E. Lymphoma. 87. 86. C. Sclerosing mesenteritis. Sclerosing mesenteritis is a rare condition of unknown cause that is characterized by chronic mesenteric inflammation. The process usually involves the mesentery of the small bowel, especially at its root, but can occasionally involve the mesocolon. On rare occasions it may involve the peripancreatic region, omentum, retroperitoneum, or pelvis. Although the cause of sclerosing mesenteritis is unknown, the disorder is often associated with other idiopathic inflammatory disorders such as retroperitoneal fibrosis, sclerosing cholangitis, rhidelthyroiditis, and orbital pseudotumor. The CT appearance of sclerosing mesenteritis can vary from subtle increased attenuation in the mesentery to a solid soft tissue mass. Sclerosing mesenteritis most commonly appears as a soft tissue mass in the small bowel mesentery, although infiltration of the region of the pancreas or porta hepatis is also possible. The mass may envelop the mesenteric vessels, and over time collateral vessels may develop. There may be preservation of fat around the mesenteric vessels, a phenomenon that is referred to as the fat ring sign. This finding may help distinguish sclerosing mesenteritis from other mesenteric processes such as lymphoma, carcinoid tumor, or carcinomatoses. Karen M., Horton MD, CT findings in sclerosing mesenteritis, paniculitis spectrum of disease. Radi 87, a 56-year-old man undergoing CT urogram displays an incidental lesion in his right adrenal gland. He is asymptomatic apart from pain in the left loin, which is currently being investigated. All these features suggest that adrenal carcinoma is more likely than a benign adenoma, except A, size more than 5 cm, B, delayed washout, C, who value of 37 on delayed contrast enhanced court, D, involvement of right kidney, E, peripheral nodular enhancement. Radiographics. 2003, 23, 615-6017. 87, C, who value of 37 on delayed contrast enhanced court features suggestive of adrenal carcinoma on imaging include large size, greater than 5 cm, invasion of other organs like liver, kidney, IVC, or diaphragm, calcification, central heterogeneous area of low density, tumor necrosis, peripheral nodular enhancement on contrast enhanced images, and delayed washout. A WHO of 37 on contrast enhanced court at 5:15 minutes after contrast injection is diagnostic of a benign adrenal lesion. Dannert W., Radiology Review Manual, 7th ed. Enhancement. 88. 88. What type of labral injury is not associated with an anterior shoulder dislocation? A. Bony Bankart lesion. B. Curtis lesion. C. Glenolabral articular disruption injury, GLAD. D. Superior labral anterior posterior tear, SLAP. E. Anterior labral ligamentous ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2011:937-8. 88. D. Superior labral anterior posterior tear, SLAP. The anteroinferior glenoid labrum is typically injured in an anterior shoulder dislocation. All of the aforementioned injuries except for the superior labral anterior posterior, SLAP, tear involve the anteroinferior labrum. The glenolabral articular disruption, GLAD, lesion is a partial tear of the anteroinferior labrum with an associated glenoid cartilage injury. Curtis lesion is a complete tear of the labrum, which is still attached to the glenoid periosteum. An anterior labral ligamentous periosteal sleeve avulsion, ALPSA, injury is similar to the Curtis lesion, but with medial displacement of the torn labrum, which is still attached to the glenoid scapula periosteal sleeve. Monster B.J., ETAL musculoskeletal imaging, the requisites, 4th ed. Philadelphia, Pa. Pa, Mosby Elsevier, 2013:8292. Periosteal sleeve avulsion injury, ALPSA. 89. A 36-year-old woman with non-remitting headache is sent for an MRI brain by the neurologist to investigate the cause of her headache. The MRI brain is mostly unremarkable apart from showing areas of hyperintensity on flare in subarachnoid spaces. All of the following conditions should be included in the differential diagnosis, except A. Pacchionian granulations. B. Slow arterial flow due to vascular stenosis. C. Subarachnoid hemorrhage. D. Infectious meningitis. E. Leptomeningeal melanosis. '89. A. Pacchionian granulations hyperintensity on flare in subarachnoid spaces has been well described in a wide range of pathologic conditions, such as subarachnoid hemorrhage, SAH, infectious or malignant meningitis, leptomeningeal spread of malignant disease, leptomeningeal melanosis, part of the neurocutaneous melanosis congenital phacomatosis, vascular hyperintensity in the subarachnoid space produced by severe, 90%, vascular stenosis, or occlusion of major cerebral vessels with resulting slow flow and fat-containing tumors like lipoma of subarachnoid space. Retrograde slow flow of engorged PL arteries through leptomeningeal anastomosis is also seen as high signal intensity in the subarachnoid space on flare in patients with Moyamoya disease, called IV sign. Other, less common, causes of subarachnoid flare hyperintensity are artifacts. Stuckey SL, ETAL hyperintensity. (90) Which of the following is false regarding bronchopulmonary sequestration? Intralobar, extralobar. A. Pleural involvement, visceral pleura, own pleura. B. Venous drainage, pulmonary veins, systemic veins. C. Associated anomalies, less common, more common. D. Symptomatic first 6 months adulthood. E. Arterial supply, aorta. 91. A. 66. D. Symptomatic first 6 months adulthood bronchopulmonary sequestration. Intralobar, extralobar. Prevalence 75%, 25%, pleural involvement, visceral pleura, own pleura, venous drainage, pulmonary veins, systemic veins, associated anomalies, less common, 15%. More common, 50%. Symptomatic adulthood first 6 months, arterial supply, thoracic aorta, etiology, acquired developmental. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2011. 91. E. Enhances. 66. Year, old man undergoing a routine staging contrast enhanced CT, chest, shows a focal non-enhancing smoothly marginate homogeneous dumbbell-shaped mass of fat attenuation confined to the interatrial septum. All of the following features may be associated with lipoma 2 hypertrophy of the interatrial septum of the heart, except A. Fatty atrial septum exceeding 2 cm in transverse diameter. B. Related to chronic corticosteroid use. C. It is bright on T1 and dark on fat-suppressed images. D. It is a recognized cause of SVC syndrome. E. Enhances avidly post-contrast. Avidly post-contrast lipoma 2 hypertrophy of the interatrial septum is defined as wedge-shaped expansion of the interatrial septum by adipose tissue exceeding 2 cm in transverse diameter. The incidence increases with age and body mass, and is also associated with chronic corticosteroid therapy. Patients are usually asymptomatic, but they may have arrhythmias or superior vena cava syndrome when the superior vena cava is encased. Lipoma 2 hypertrophy of the interatrial septum, in contrast to cardiac lipoma, does not have a capsule. Because lipoma 2 hypertrophy of the interatrial septum spares the fossa ovalis, it often has a dumbbell-shaped appearance. Lipoma 2 hypertrophy of the interatrial septum has the same density and signal intensity as fat on CT and MR, respectively. Lipoma 2 hypertrophy of the interatrial septum is hypointense on fat saturation sequences, and does not enhance post-contrast. Post-contrast. Francois CJ, ETALCT, and MR imaging of primary, metastatic, and non-neoplastic cardiac masses. Contempt Diane Radiol. 2006:29, 24. 92. A 25-year-old music teacher has recently been diagnosed with inflammatory bowel disease. She has an MRI small bowel study for evaluation of her disease status. Regarding features of Crohn's versus ulcerative colitis on cross-sectional imaging, which of the following options is false? Crohn's ulcerative colitis. A. Ccam sign yes yes. B. Full thickness enhancement yes no. C. Fiber fatty proliferation yes no. D. Enlarged lymph nodes yes yes. E. Skip lesions yes yes. (24:16). 92. E. Skip lesions yes yes in patients with proved or suspected Crohn's disease. Cross-sectional images should be analyzed specifically for the presence and character of a pathologically altered bowel segment, wall thickness, pattern of attenuation, degree of enhancement, length of involvement, stenosis and prestenotic dilatation, skip lesions, fistulas, abscess, fibrovatty proliferation, increased vascularity of the vasa recta, comb sign, mesenteric adenopathy, and other extra. Intestinal disease involvement. Furukawa A. Cross-sectional imaging in Crohn's disease. Radiographics. 2004, 24:689-702. Yes. 93. According to standards of intravascular contrast agent administration to adult patients, 2nd edition, RCR 2015, all are true regarding patients on metformin, except A. Metformin need not be stopped prior to contrast enhanced CT if serum creatinine is normal. B. Metformin need not be stopped prior to contrast examination if eGFR is greater than 60. C. If serum creatinine is above normal range, metformin should be withheld for 24 hours. D. If eGFR is 60, the decision to withhold metformin should be made in consultation with the clinical team. E. There is lack of evidence about whether lactic acidosis is really an issue post-iodinated contrast in metformin users. (93) C. If serum creatinine is above normal range, metformin should be withheld for 24 hours. Metformin is not recommended for use in diabetics with renal impairment because it is excreted exclusively via the kidneys. Accumulation of metformin may result in the development of lactic acidosis, a serious complication. There is lack of any valid evidence that lactic acidosis is really an issue after administration of iodinated contrast media in patients taking metformin. The problems caused to patients and clinicians by stopping the drug, and its increasing use in poorly controlled diabetic patients regardless of renal function, have been considered when formulating this advice. It does, however, remain the case that renal function should be known in patients taking metformin who require intravenous or intraarterial iodinated contrast medium administration. There is no need to stop metformin after contrast in patients with serum creatinine. within the normal reference range and / or EGFR greater than 60 ml/min/1.73 m2. If serum creatinine is above the normal reference range or EGFR is below 60, any decision to stop metformin 4. Chapter 2. Test paper 1, answers. 48 hours following contrast medium administration should be made in consultation with the referring clinic. Standards for users. 94. A motorcyclist is brought into the A&E department with limb fractures and neck pain. Preliminary cervical spine radiographs review mild anterolesthesis, 10%, at C4/5 with slight overlap of the facet joints. CT shows a right naked facet sign at this level. What statement is false in regard to this injury? A. It is an unstable injury. B. Standards for intravascular contrast administration to adult patients, 3rd ed. Royal College of Radiology. Referring clinic. Standards for intravascular contrast administration to adult patients, 3rd ed. Royal College of Radiologists, 2015. BFCR, 15, 1. 94, A. It is an unstable injury. Unilateral facet joint dislocation occurs from a flexion/distraction injury with a rotatory component. It is a stable form of facet joint dislocation, CF with highly unstable bilateral facet joint dislocation. The naked facet sign is seen involving one facet joint on CT, and on plain radiograph there's often an overlapping appearance to the facet joints. Mild anterolesthesis and widening of the interspinous space at the level of injury is a common finding. Up to 30% of patients have a neurological deficit. Shapiro, S.A. Management of unilateral locked facet of the cervical spine. Neurosurgery. 1994, 33, 58, 32-7. Anterolesthesis is a common finding. C. It is a stable injury. D. There is widening of the interspinous space. E. It is often associated with a neurological deficit. 95. A 76-year-old woman has been rushed to the stroke unit with features of acute stroke. A CT brain obtained in the A&E department on arrival is normal. A conventional MRI brain is performed. Which of the following statements regarding the imaging evaluation of an acute cerebral infarction by MR is false? A. It may demonstrate parenchymal microhemorrhages on SWI, susceptibility. 7. 95. C. SWI is based on homogeneity of magnetic field. Gradient echo and susceptibility-weighted sequences are the most sensitive sequences for depicting hemorrhagic transformation in patients with ischemic stroke, particularly susceptibility-weighted imaging. Susceptibility-weighted MRI utilizes magnetic artifacts generated by inhomogeneities of the magnetic field. Deoxyhemoglobin produces a non-uniform magnetic field, which accounts for signal changes seen in acute hemorrhages and for the blood oxygen level dependent effect. With SWI, intraparenchymal hemorrhages can be seen within the first hour of bleeding, with high sensitivity and accuracy. SWI enables the visualization of multiple cerebral microbleeds, which have been shown to be a risk factor for intracranial hemorrhage after stroke, both with and without thrombolytic therapy. S.A. de Camargo E.C., Corochetz W.J. Neuroimaging of ischemia and infarction. NeuroRx. 2005, 2, 7. Susceptibility-weighted imaging. B. SWI shows intraparenchymal hemorrhage within hours. C. SWI is based on homogeneity of magnetic field. D. Deoxyhemoglobin produces a non-uniform magnetic field. E. Microbleeds on SWI are a risk factor for intracranial hemorrhage after stroke. Stroke. 96. A 10-year-old boy presents with fever and eosinophilia. MRI of the head shows thickening of the infundibular stalk and a markedly enhancing mass in the superior aspect of the stalk. There is also enhancement in the sella extending along the left petrous temporal bone with poorly defined borders. The features are consistent with A. Meningioma, B. Petrous apophysis, C. Histiocytosis, X. Chapter 1. Test paper 1, questions. 76. 96. C. Histiocytosis X space-occupying lesions affect the hypothalamic neurohypophyseal axis, which is the central nervous system site most commonly and often earliest involved in Langerhans cell histiocytosis. MRI findings have been correlated with symptoms of diabetes insipidus, which is a clinical hallmark of the condition. Typically, the formation of Langerhans cell histiocytosis granulomas leads to a loss in the normally high signal intensity of the posterior neurohypophysis on T1 weighted images. Furthermore, the hypothalamus, the pituitary stalk, or both are frequently enlarged and demonstrate gradually increasing homogeneous enhancement after an intravenous injection of gadolinium, without subsequent washout. The differential diagnosis includes other infundibular diseases, such as adenohypophysitis, which can be differentiated from Langerhans cell histiocytosis by a sharp increase in contrast enhancement and rapid washout. After the administration of the intravenous contrast medium, granulomatous diseases such as sarcoidosis, Wegener disease, and leukemia must also be considered in the differential. Rarer differentials are germ cell tumors, germinoma, teratoma, and hemangioblastoma. These produce the same MRI features, with the same pattern of enhancement at dynamic imaging. The second most frequent pattern of central nervous system involvement in Langerhans cell histiocytosis is characterized by intraaxial neurodegenerative changes. Bilateral symmetric lesions in the cerebellum, especially the dentate nucleus, basal ganglia, or brainstem, are most often observed. The differential diagnosis includes ADEM, acute multiphasic disseminated encephalitis, various metabolic and degenerative disorders, leukoencephalopathy secondary to chemotherapy or radiation therapy, and paraneoplastic encephalitis. Chapter 2. Test paper 1, answers. 52. Less frequently, Langerhans cell histiocytosis granulomas, which resemble tumors, are observed in the extraaxial space in the meninges, pineal gland, choroid plexus, and spinal cord. Schmidt S. ETAL extraosseous Langerhans cell histiocytosis in children. Radiographics. 2008, 28, 370726. 97. C. Bronchogenic pericardial metastases are much more common than primary pericardial tumors. Breast and lung cancers are the most common sources of metastases in the 18. D. Craniopharyngioma E. Neuroblastoma metastasis. Metastasis. 97. Follow-up CT chest done on a 71-year-old man with previous history of malignancy shows a mass lesion in the heart. It is new compared to previous CT scans and is determined to represent a metastatic deposit. Which of the following types of malignancy is most likely to be the primary in this case? A. Colonic. B. Esophageal. C. Bronchogenic. D. Renal cell. E. Astrocytoma. 90. Pericardium, followed by lymphomas and melanomas. Wang ZJ, ETALCT, and MR imaging of pericardial disease. Radiograph. 98. A 30-year-old weightlifter presents with swelling in the right groin. Which of the following is false? A. Direct inguinal hernia. The hernial sac lies lateral to the inferior epigastric artery and above the pubic tubercle. B. Femoral hernia. The hernial sac lies medial and adjacent to the femoral vessels. C. Indirect inguinal hernia. The hernial sac lies lateral to the inferior epigastric artery and superior to the inguinal ligament. D. Obturator hernia. The hernial sac lies between the obturator externus and internus. E. Spigelian hernia. The hernial sac lies between the rectus abdominis medially and the semilunar line laterally. 99. A 43-year-old man has recently had a renal transplantation. All of the following are true regarding investigation of transplanted kidney, except A. ATN. Radiographics. 2003, 23, S16780. 98. A. Direct inguinal hernia. The hernial sac lies lateral to the inferior epigastric artery and above the pubic tubercle. There are several sites on the abdominal wall prone to herniation. The first site is the deep inguinal ring, where an indirect inguinal hernia occurs. Here, herniated structures enter the inguinal canal lateral to the inferior epigastric artery and superior to the inguinal ligament, extending for a variable distance through the inguinal canal. A second site of herniation is at the inferior aspect of the Hesselbach's triangle, where a direct inguinal hernia usually occurs. This weakened area is just lateral to the conjoint tendon and medial to the inferior epigastric artery, in contrast to the indirect inguinal hernia, which originates lateral to the inferior epigastric artery. A third weakened area is inferior in relation to the inguinal ligament and lateral to the lacunar ligament, where femoral hernia occurs, typically medial and adjacent to the femoral vessels. The fourth area is at the lateral margin of the rectus abdominis muscle, superior to the inferior epigastric artery as it crosses the linea semilunaris, where Spigelian hernia occurs. Indirect inguinal hernias are most common regardless of sex. Femoral hernias are more common in women. Jamadar sonography of inguinal region hernias. AJR AMJ Röntgenol. 2000. Acute tubular necrosis is depicted by normal perfusion and reduced excretion. B. Normal perfusion and reduced. (2006) 187:18590. 99. C. Reduced diastolic flow is specific for acute rejection. Acute rejection is a cell-mediated reaction seen within 1-4 weeks. Doppler shows decreased diastolic flow, causing a high resistance index greater than 0.8 and low pulsatility index. However, it is a non-specific finding also seen with acute tubular necrosis, cyclosporin toxicity, acute pyelonephritis, obstruction, renal vein thrombosis, and compression by perirenal collections. A high resistive index, more than 0.9, is relatively specific for acute rejection. Some centers use pulsatility index. A pi of more than 1.5 is used for diagnosing rejection. MRI shows increased cortical signal intensity and loss of corticomedullary differentiation on T1 weighted scans. Acute tubular necrosis is common in the early postoperative period and results in reduced function, which gradually recovers over the next few weeks to months. There is no graft tenderness or fever, unlike acute rejection. The scintigraphic findings are abnormal immediately after surgery. The perfusion phase is relatively maintained well. Later phases show slow washout and persistent isotope accumulation. In contrast, if the isotope study is normal in the early postoperative phase and becomes abnormal subsequently, acute rejection can be diagnosed confidently. Thrombosis of the renal vein is rare and typically occurs in the early postoperative phase. The transplant appears swollen and hypoechoic on US. Doppler US shows the absence of flow in the veins and sharp systolic waves, with reverse diastolic flow. Resistivity index is markedly elevated. Cyclosporin is Cyclosporin is nephrotoxic and causes a dose-dependent reduction of renal function. The imaging findings are nonspecific. The perfusion phase of the 99-MTCD-TPA study is normal. Chapter 2. Test paper 1, answers. But there is prolonged clearance of 99-MTC-MAG3. Normal perfusion and delayed excretion are also seen in obstruction. Ragia P. ETAL renal trans. A. ATN, acute tubular necrosis, is depicted by normal perfusion and reduced excretion. B. Normal perfusion and reduced excretion is nonspecific. C. Reduced diastolic flow is specific for acute rejection. D. During acute rejection, T1W of renal cortex increases. E. Renal vein thrombosis causes characteristic waveform changes. 100. What is the role of ultrasound in the evaluation of ischemic injury? A. To evaluate for the presence of a joint effusion. B. To assess joint mobility on dynamic ultrasound C. To look for an Anderson lesion D. To look for a steno lesion E. To look for associated extensor polycystic tenosynovitis. Transplant imaging and complications. Abdom imaging. 2006, 31:73546. 100 D. To look for a steno lesion skier's thumb, otherwise known as gamekeeper's thumb, is an injury to the ulnar collateral ligament (UCL) of the first MCP joint. Most of the injuries to the UCL are managed conservatively. However, in complete tears, the UCL may retract and slip to lie superficial to the adductor pollicis aponeurosis or muscle. This prevents healing of the UCL as the adductor pollicis aponeurosis muscle is now interposed between the torn ends of the UCL, which is known as a steno lesion. Ultrasound is primarily performed to identify this abnormality, as this requires surgical correction. Anderson lesion refers to the vertebral end plate changes seen in rheumatic spondylolischitis. Monster BJ, ETAL musculoskeletal imaging, the requisites, 4th ed. Philadelphia, PA, Mosby Elsevier, 2013:139. 101. D. It is never seen beyond 2 weeks. Cortical laminar and pseudolaminar necrosis cause serpiginous cortical T1 shortening. Tenosynovitis. 101. A 76-year-old woman with a recent episode of right arm weakness is being followed up with an MRI a week after her presentation to the A&E department. The current MRI shows changes on T1W images, which were identified as cortical laminar necrosis at the stroke meeting. Which of the following statements regarding cortical laminar necrosis is false? A. Laminar necrosis is seen as serpiginous high signal on T1W MRI. B. It is thought to be due to lipid-laden macrophages. C. It can be seen 3-5 days after stroke. D. It is never seen beyond 2 weeks. E. SWI helps differentiate from hemorrhagic transformation. 102. Regarding Chiari-2 malformation. Shortening, which is not caused by calcium or hemoglobin products. Rather, it presumably results from some other unknown substance or paramagnetic material, possibly lipid-laden macrophages. High cortical signal intensity may be seen on T1, weighted images 3-5 days after stroke, and in many cases it is seen about 2 weeks after stroke. Thereafter it increases in intensity and fades after about 3 months, but in some cases it may persist for more than a year. In patients with suspected cortical laminar necrosis, susceptibility-weighted imaging may help differentiate it from hemorrhagic transformation. Allen LM, ETAL sequence-specific MR imaging findings that are useful in dating ischemic stroke. Malformations, which of the following is true? A. Supratentorial abnormalities are uncommon. B. The tentorial attachment is usually normal. C. It is nearly always associated with failure of neural tube closure. Chapter 1. Test paper 1, questions. 19. D. Hemorrhagic transformation is rare in the first 6 hours. E. Parenchymal hemorrhages are rarer than microbleeds. (108) The following are C. It is nearly always associated with failure of neural tube closure. Chapter 1. Test paper 1, questions. 19. D. The severity of hydrocephalus nearly always improves after repair of the meningocele. E. Batwing appearance of the occipital horns. Allen LM, ETAL sequence-specific MR imaging Allen LM, ETAL sequence-specific MR imaging findings that are useful in dating ischemic stroke. Radiographics. 2012, 32, 512, 85, 97. 102. C. It is nearly always associated with failure of neural tube closure. Chiari-2 malformation is characterized by a caudally displaced fourth ventricle and brain stem, as well as tonsillar/vermian herniation through the foramen magnum. Spinal anomalies are extremely common, lumbar meningomyelocele, 95%, and syringohydromyelia. Supratentorial abnormalities are common, dysgenesis of corpus callosum, 80%, obstructive hydrocephalus following closure of meningocele, absent septum pellucidum, to name a few. CT and MRI show colpocephaly, enlarged occipital horn and atria, batwing configuration of frontal horns on cornal view, pointing inferiorly secondary to enlarged caudate nucleus, hourglass ventricle, excessive cortical gyration, stenogyria, interdigitation of medial cortical gyri, cerebellar peg sign, thin elongated fourth ventricle exiting below the foramen magnum, dysplastic tentorium, towering cerebellum, tethered cord and cervicomedullary kink among multiple other cranial and spinal anomalies. It is not associated with basilar impression/C1 assimilation/Klippel deformity. Deformity. 103. A 42-year-old man presents with a high-grade fever, splenomegaly, and abdominal pain. CT chest and abdomen done to look for a source of sepsis show multiple small cavitating lesions in both lungs with areas of hypoattenuation in the spleen and kidneys. Which of the following is the most likely diagnosis? A. Sarcoidosis. Sarcoidosis. B. Carcinoid heart disease. C. Amyloidosis. D. Infective endocarditis. E. Rheumatic heart disease. Deformity. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, Pa. Lippincott, Williams and Wilkins, 2011. 103. D. Infective endocarditis. Extracardiac complications of infective endocarditis. Central nervous system embolic stroke, intracranial hemorrhage, intracranial mycotic aneurysm, brain abscess, meningitis thoracic septic pulmonary emboli, pulmonary edema, pulmonary abscess, pleural effusion/empyema, pneumothorax. Chapter 2. Abdominal renal infarction, renal failure, splenomegaly, splenic infarction, hepatic infarction, mesenteric ischemia, musculoskeletal spondylolischitis, osteomyelitis, septic arthritis, peripheral soft tissue abscess, vascular major arterial emboli, mycotic aneurysm, including aortic aneurysm, vasculitis, including aortes. TW, ETAL radiologic manifestations of extracardiac complications of infective endocarditis. Radiol. 2008, 18:24-33-45. Disease. 104. A 50-year-old woman has a CT abdomen and pelvis for nonspecific abdominal pain. The scan shows a 7 cm low-density lesion in segment 7 of the liver with heterogeneous enhancement in arterial and portal venous phase. An MRI liver is performed for further characterization and shows a large lobulated mass with low signal on T1W and intermediate to high signal on T2W. On the dynamic post-contrast T1 scans, it shows enhancement in the arterial phase with a non-enhancing central scar, which later enhances in the delayed phase. What is the most likely diagnosis? A. Focal nodular hyperplasia. B. Fibrolamellar HCCC, adenoma. D. Hemangioma. E. Hepatocellular carcinoma. 105. A 42-year-old woman is referred to the breast clinic and is due an ultrasound scan to evaluate a suspected lump. 104. A. Focal nodular hyperplasia. Focal nodular hyperplasia, FNH, is the second most common benign liver tumor after hemangioma. FNH is classified into two types, classic, 80% of cases, and non-classic, 20%. Distinction between FNH and other hypervascular liver lesions such as hepatocellular adenoma, hepatocellular carcinoma, and hypervascular metastases is critical to ensure proper treatment. An asymptomatic patient with FNH does not require biopsy or surgery. MRI has higher sensitivity and specificity for FNH than does US or CT. Typically, FNH is ISO, or hypointense on T1, weighted images, is slightly hyper, or isointense on T2, weighted images, and has a hyperintense central scar on T2, weighted images. FNH demonstrates intense homogeneous enhancement during the arterial phase of gadolinium-enhanced imaging, and enhancement of the central scar during later phases. Hussein SM, ETAL focal nodular hyperplasia, findings at state-of-the-art MR imaging, US, CT, and pathologic analysis. Radiographics. 2004, 24:319. Lump in the breast. All of the following are ultrasonographic features of a benign breast mass, except A, feeding central vessel. Vessel on Doppler imaging B. Well-defined smooth margin C. 3 or fewer lobulations D. Circumferential blood flow pattern on Doppler imaging E. Uniform hyperechogenicity. 106. A 6-year-old girl presents to her family doctor with fever and pain in the lower left leg. Blood tests reveal leukocytosis and anemia. Plain X-ray of the leg shows a destructive lesion involving the fibular shaft with lamellated onion skin periosteal reaction, cortical destruction, and large soft tissue mass. What is the likely diagnosis? A. Osteosarcoma B. Ewing sarcoma C. Chondroblastoma D. Chondromyxoid fibroma E. Osteoid osteoma. 19. 105. A. Feeding central vessel on Doppler imaging. US features characteristic of benign lesions have been described. These include hyperechogenicity compared to fat, an oval or well-defined, lobulated, gently curving shape, and the presence of a thin echogenic pseudocapsule. Doppler examination of benign lesions shows displacement of normal vessels around the edge of the lesion. In contrast, malignant lesions show abnormal vessels that are irregular and centrally penetrating. Adam A. ETAL Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008:1180. 106. B. Ewing sarcoma. The main differential in such findings would be between infection and a primary bone tumor. Because infection has not been given as an option, the choices would be between osteosarcoma and Ewing sarcoma. Ewing sarcoma tends to occur in both the appendicular and axial skeleton equally, whereas osteosarcoma mostly occurs in the appendicular skeleton. Ewing sarcoma usually begins in the diaphysis of the long bones, whereas osteosarcoma tends to occur in the metaphysis. Ewing sarcoma may also have a large extraosseous component. The two are often differentials of each other, as each can have a large overlap of imaging findings, but the above traits can help one sway towards the other. Dannert W. Radiology Review Manual, 6th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2007:75. Can J.H. Kleinman. Osteoma. 107. A 67-year-old man with a history of head and neck cancer presents with acute stroke symptoms, and MRI is performed. SWI images show several tiny microbleeds in the basal ganglia at 48 hours. All of the following are true regarding hemorrhagic transformation in stroke, except A. Microbleeds have worse prognosis than hematoma. B. Fewer than 5 microbleeds does not contraindicate thrombolysis. C. Parenchymal hemorrhage is common in the basal ganglia. Chapter 1. D. Hemorrhagic transformation is rare in the first 6 hours. E. Parenchymal hemorrhages are rarer than microbleeds. 108. The following are diagnosed prenatally on ultrasound examination or MRI, except A. Pulmonary interstitial emphysema B. Bronchial atresia. Kleinman PK, Pediatric and Adolescent Musculoskeletal MRI A case-based approach. Secaucus, New Jersey, Springer Verlag, 2007, 23-4. 107. A. Microbleeds have a worse prognosis than hematoma. Hemorrhagic transformation demonstrates a spectrum of findings ranging from small microbleeds to large parenchymal hematoma. Several studies have reported that microbleeds are present in 1/2 to the majority of patients with ischemic stroke, and are seen around 48 hours after onset of symptoms. Studies have shown that these areas of microbleeding are not associated with a worse outcome, and guidelines state that the presence of fewer than 5 areas of microbleeding on initial MRIs does not contraindicate thrombolysis. Chapter 2. Test Paper 1, Answers. 55. Parenchymal hematoma is a rare type of hemorrhagic transformation that results from vessel wall rupture caused by high reperfusion pressure. It is more common with cardioembolic events, is associated with hyperglycemia, most commonly occurs in the basal ganglia, and confers a much worse prognosis. Hemorrhagic transformation is rare in the first 12 hours after stroke onset, the hyperacute stage, particularly within the first 6 hours. When it occurs, it is usually within the first 24-48 hours and in almost all cases, is present for 5 days after stroke. Studies have reported that the presence of early parenchymal enhancement within 6 hours of stroke is associated with a higher risk for clinically significant hemorrhagic transformation. Allen LM, ETAL sequence-specific MR imaging findings that are useful in dating ischemic stroke. Radiographics. 2012, 32, 512, 85, 97. Atresia C. Pulmonary sequestration D. Congenital pulmonary airway obstruction E. Congenital diaphragmatic hernia. 109. All of the following are causes of a right-sided cardiac thrombus. 97. 108. A. Pulmonary interstitial emphysema. Emphysema MRI's excellent tissue contrast resolution allows easy differentiation between organs, allowing prenatal diagnosis of congenital diaphragmatic hernia. MRI is also useful in the evaluation of fetal lung maturation through volume and signal intensity. Congenital cystic adenomatoid malformation, CCAM, is the most commonly diagnosed lung malformation. In CCAM, abnormal branching of the immature bronchioles and lack of normal alveolar development results in a solid/cystic intrapulmonary mass. Most pulmonary sequestrations detected prenatally are extralobar, with an anomalous vein that drains into the systemic circulation. On T2 weighted images, they are seen as well-defined hyperintense masses with or without hypointense septa. Intralobar sequestration may be difficult to differentiate from CCAM. MRI is also useful for evaluating other pulmonary and thoracic anomalies. Bronchogenic cysts. are identified as hyperintense lesions on T2 weighted sequences. They are usually single lesions located in the lung or mediastinum. Esophageal duplication cysts are also identified as hyperintense mediastinal lesions. Congenital lobar emphysema can be difficult to distinguish from intralobar sequestration and from Ccam. Pulmonary interstitial emphysema refers to the abnormal location of air within the pulmonary interstitium, resulting from rupture of overdistended alveoli following barotrauma in infants who have surfactant deficiency lung disease. Martin C. ETAL fetal MR in the evaluation of pulmonary and digestive system pathology. Insights Imaging. 2012, 332. Except A, DVTB, Besset syndrome C, Loeffler syndrome D, infective endocarditis E, sarcoidosis. 110, a 40-year-old woman with a known history of connective tissue disease presents to her gastroenterologist with nonspecific upper abdominal pain and weight loss. She is referred for a barium follow-through, which shows that the small bowel folds are of normal morphology, but distended and closely spaced together with delayed emptying of barium into the large bowel. There are also a number of jejunal diverticula. She had an X-ray of her left hand a few weeks earlier, which showed resorption of the distal tufts of her phalanges. What is the most likely unifying diagnosis? A. Hyperparathyroidism B. Whipple's disease C. Scleroderma D. Amyloidosis E. Celiac disease. 111, a Francois CJ, ETALCT, and MR imaging of primary, metastatic, and non-neoplastic cardiac masses. Contempt Diane Radiol. 2006:29, 2416. 110, C. Scleroderma systemic sclerosis, or scleroderma, is characterized by excessive collagen production, autoimmune disease-induced inflammation, and microvascular injury. It is divided into two subtypes, limited cutaneous systemic sclerosis and diffuse cutaneous systemic sclerosis. Limited cutaneous systemic sclerosis typically manifests as Crest syndrome, which stands for calcinosis. Chapter 2. Test paper 1, answers. 56. Cutis, Raynaud phenomenon. A 42-year-old woman is referred to the breast clinic and is due an ultrasound scan to evaluate a suspected lump in the breast. All of the following are ultrasonographic characteristics of breast malignancy, except A. Perpendicular radiating spiculations B. Anechoic mass C. Irregular margins of a mass D. Mass that is taller than it is wide E. Posterior acoustic shadow from a solid mass. Phenomenon, esophageal dysmotility, sclerodactyly and telangiectasia, and is generally anti-centromere antibody positive. The systemic manifestations of systemic sclerosis are diverse. Abnormalities of the circulatory system, most notably Raynaud phenomenon, and involvement of multiple organ systems such as the musculoskeletal, renal, pulmonary, cardiac, and gastrointestinal systems with fibrotic or vascular complications are most common. Nearly 90% of patients with systemic sclerosis have evidence of gastrointestinal involvement, which is ultimately a substantial cause of morbidity. The underlying pathologic change consists of smooth muscle atrophy and fibrosis caused by collagen deposition primarily in the tunica muscularis. Esophageal involvement typically affects the distal 2/3 of the esophagus because of the lack of striated muscle in the upper 1/3. Findings of esophageal involvement include decreased or absent esophageal peristalsis combined with prominent gastroesophageal reflux from an incompetent lower esophageal sphincter. Esophagitis is frequently present, and associated complications such as esophageal stricture or Barrett metaplasia are fairly common. Small bowel findings include hypomotility from smooth muscle atrophy and fibrosis, which leads to stasis, dilatation, and pseudoobstruction. The hidebound sign of valvular packing is a fairly specific finding, and may be seen in as many as 60% of patients with scleroderma. BOFS are as abdominal manifestations of neurologic disorders. Radiographics. 2013, 33:135:53. 111, B. Anechoic mass carcinomas are irregular in outline, ill-defined and hypoechoic compared to the surrounding fat. They are taller than wide, AP dimension more than transverse dimension. There may be an ill-defined echogenic halo around the lesion, particularly the lateral margins, and distortion of the adjacent breast tissue, akin to spiculations, may be evident. Posterior acoustic shadowing is frequently observed, due to attenuation of the US beam by dense tissue. Doppler examinations of malignant lesions show abnormal vessels that are irregular and centrally penetrating. Adam A. ETAL Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008:1184. Mass. 112, a 70-year-old man with a history of a scaphoid fracture several years ago is referred to the orthopedic clinic for increasing wrist pain. A plain X-ray is ordered to check for developing OA and assess the midcarpal joints. Measurements based on the true lateral view reveal the capitolunate angle is 30 degree and the scapholunate angle is 80 degree. What is your diagnosis? A. Volar intercalated segment instability, VISI. B. Dorsal intercalated segment instability, DISI. C. Refracture of scaphoid. D. Pterolunate dislocation. E. Scapholunate advanced collapse, SLAC. Deformity. 112, B. Dorsal intercalated segment instability, DISI, and VISI injuries refer to malalignment of the carpal rows with emphasis of the relation of the lunate to the capitate. In DISI, associated with tear of scapholunate ligament, the lunate is tilted dorsally with an increased scapholunate angle greater than 60 degrees, and capitolunate angle greater than 30 degrees. In VISI, associated with tear of the lunotriquetral ligament, there is a volar tilt of the lunate with decreased scapholunate angle 30 degrees, and increased capitolunate angle greater than 30 degrees. Monaster BJ, ETAL musculoskeletal imaging, the requisites, 4th edition. Philadelphia, PA, Mosby Elsevier, 2013:130. 113, D. Low signal on T1W MRI is seen greater than 8 hours. A good rule of thumb is that if the signal intensity on ADC maps is low, the stroke is less than 1 week old. Most literature indicate that in patients with ischemic stroke, findings on FLAIR images are positive 6-12 hours after onset of symptoms. Symptoms. Sometimes the presence of restricted diffusion with negative findings at FLAIR imaging alone has been enough to initiate treatment. High signal intensity is not usually seen at T2, weighted imaging until at least 8 hours after the initial ischemic insult and continues into the chronic phase. Low signal intensity is not usually seen at T1, weighted imaging until 16 hours after the onset of stroke and persists into the chronic phase. The pattern of contrast enhancement may help determine the age of the stroke. In ischemic stroke, enhancement may be arterial, meningeal, or parenchymal. Arterial enhancement, dubbed the intravascular enhancement sign, usually occurs first and may be seen as early as 0-2 hours after the onset of stroke. Meningeal enhancement is the rarest type of enhancement. Chapter 2. Test Paper 1, Answers. 57. It occurs within the first week after onset of stroke. If parenchymal enhancement persists longer than 8-12 weeks, a diagnosis other than ischemic stroke should be sought. Allen L.M. Deformity. 113, a 49-year-old woman with right lower extremity weakness and rigidity undergoes MRI with DWI, ADC map, FLAIR, T2W, and T1W pre- and post-gadolinium images. Early hyperacute stroke is diagnosed. All of the following are true about the timing of stroke and MRI, except A. Low ADC signal suggests that the stroke is less than a week old. B. FLAIR hyperintensities are seen in 6-12 hours. Chapter 1. Test Paper 1, Questions. 21. C. High signal on T2W MRI is seen greater than 8 hours. D. Low signal on T1W MRI is seen greater than 8 hours. E. Parenchymal enhancement generally doesn't persist beyond 8-12 weeks. 114. A neonate has an umbilical venous catheter inserted. On an abdominal X-ray, it has advanced up to the level of T10 at the midline. In which structure is the tip of the catheter? A. Left portal vein. B. Right portal vein. Vein C. Ductus venosus. D. Superior mesenteric vein. E. Splenic vein. It occurs within the first week after onset of stroke. If parenchymal enhancement persists longer than 8-12 weeks, a diagnosis other than ischemic stroke should be sought. Allen L.M. ETAL sequence-specific MR imaging findings that are useful in dating ischemic stroke. Radiographics. 2012, 32, 512, 85, 97. 114. C. Ductus venosus. The single umbilical vein extends from the umbilicus to the left portal vein. When blood from the umbilical vein reaches the left portal vein, it is directed to the ductus venosus, which originates from the left portal vein immediately opposite the insertion site of the umbilical vein and courses cephalad to the inferior vena cava. The preferred location of the tip of the umbilical venous catheter is typically in the cephalad portion of the inferior vena cava, or at the inferior vena cava right atrial junction. An umbilical venous catheter can be distinguished from an umbilical arterial catheter, as the UVC travels cranially in the umbilical vein, while the UAC travels caudally in an umbilical artery to reach a common iliac artery. Schlesinger AE, ETAL neonates and umbilical venous catheters, normal appearance. 115. Which of the following statements concerning malignant cardiac masses is false? A. Cardiac metastasis outnumbers primary cardiac malignancy. B. Angiosarcomas have a high T1 signal due to methemoglobin. C. Undifferentiated sarcomas mostly affect the left atrium. D. Primary cardiac lymphomas mostly affect the left side of the heart. E. Rhabdomyosarcoma commonly affects the valve. 116. A 30-year-old cab driver presents to his GP with malaise, jaundice, and abdominal distension. Blood tests performed show deranged liver function tests. A provisional diagnosis. Appearance, anomalous positions, complications, and potential aid to diagnosis. AJR AMJ Rentgenol. 2003, 180, 4114753. 115. D. Primary cardiac lymphomas mostly affect the left side of the heart. Secondary malignancies involving the heart are 20-40 times more frequent than primary cardiac neoplasms. Angiosarcoma is the most common primary cardiac malignancy of adulthood. The tumor typically involves the right atrium, and so presenting symptoms are related to obstruction to right cardiac filling and pericardial tamponade. They are heterogeneously high signal on T1 and T2, weighted images with heterogeneous enhancement. Undifferentiated sarcoma mostly arises in the left atrium, although they can also involve the cardiac valve. It appears as an isointense irregular mass infiltrating the myocardium. Primary cardiac lymphomas are exceedingly rare, are typically of the non-Hodgkin B-cell type, and are confined to the heart or pericardium. They most commonly involve the right side of the heart, in particular the right atrium, with frequent involvement of more than one chamber and invasion of the pericardium. At MRI, they are isointense on T1, weighted images and heterogeneously hyperintense on T2, weighted images. They demonstrate heterogeneous enhancement after administration of gadolinium contrast material. Rhabdomyosarcomas do not arise from any specific chamber, but they are more likely than any other primary cardiac sarcomas to involve the valves. Sparrow PJ, ETAL MR imaging of cardiac tumors. Radiographics. 2005, 25, 512, 55, 76. 116. C. There is caudate lobe atrophy in chronic Budgeari. Budgeari syndrome is a heterogeneous group of disorders characterized by hepatic venous outflow obstruction at the level of the hepatic veins, the IVC. Diagnosis of Budgeari syndrome was made. All of the following are imaging features of Budgeari syndrome, except A. Ultrasound demonstrates portal vein enlargement and change in IVC, or the right atrium. Flow dynamics. B. In acute Budgeari, the liver is globally enlarged with lower attenuation on CT. C. There is caudate lobe atrophy in chronic Budgeari. D. CT shows non-homogeneous liver enhancement with a predominantly central area of enhancement and delayed enhancement of the periphery. E. On MRI, the liver is low signal on unenhanced T1 and T2 and delayed enhancement post-contrast. 117. All of the following are major indications for ultrasound of the breast, except A. Delineation of cystic from solid breast masses. B. Evaluation of a palpable breast mass in a mammographically dense breast. C. Evaluation of nipple discharge in a mammographically dense breast. D. Evaluation of breast lesions not well seen on mammography. E. Routine breast screening. 118. A 19-year-old man is reviewed. Atrium. Budgeari syndrome has variable imaging features. Hepatic vein or IVC thrombosis, with resultant changes in liver morphology and enhancement patterns, venous collaterals, varices, and ascites may be directly observed. Duplex Doppler US is a useful method for detecting Budgeari syndrome because it allows easy assessment of hepatic venous flow and detection of hepatic parenchymal heterogeneity. CT and MR imaging also can depict hepatic venous flow or thrombosis and IVC compression or occlusion. In the presence of acute disease, the imaging features correspond with histologic findings of liver congestion and edema. The liver is globally enlarged, with lower attenuation on CT images, decreased signal intensity on T1, weighted MRIs, and heterogeneously increased signal intensity on. Chapter 2. T2 weighted MRIs, predominantly in the periphery. Differential contrast enhancement between the central and peripheral areas of liver parenchyma is a feature of acute Budgeari syndrome. The more edema and congested peripheral regions demonstrate decreased contrast enhancement, whereas stronger enhancement is seen in the central parenchyma. After the administration of contrast material, increased enhancement is seen in areas of venous drainage that are less affected, such as the caudate lobe. The development of intra- and extrahepatic collateral veins in subacute Budgeari syndrome permits the egress of venous flow, producing a more homogeneous enhancement pattern with persistent signs of edema. In chronic Budgeari syndrome, there is atrophy of the affected portions of the liver, and the parenchymal edema is replaced by fibrosis, which results in decreased T1 and T2 weighted signal intensity at unenhanced MRI and in delayed enhancement in contrast-enhanced studies. Hypertrophy of the caudate lobe, irregularities of the liver contour, and regenerative nodules are prominent features of chronic Budgeari syndrome. Cora M. Diagnostic and interventional radiology for Budgeari syndrome. Radiographics. 2009, 29:66981. 117. E. Reviewed at a clinic for a persistent ache in his lower back that has not improved for routine breast screening. Ultrasound is not a screening tool. It is used for assessment of a palpable lump, particularly in young patients below 30 years and mammographically dense breasts, and in characterization of a mammographic or palpable mass as solid or cystic. It is used for evaluation of mammographically uncertain lesion or for confirmation of lesion seen on a single projection. It is used for assessing breast discharge, suspected silicone leaks, follow-up of lesions seen on US, and for guiding cyst aspiration, biopsy, or wire localization. Over 3 months. He is an avid mountain biker, but there is no history of significant trauma, and there are no neurological deficits. The patient is found to have mild increase in thoracic kyphosis with mild wedging of the T4, T5, and T6 vertebrae. MRI reveals the presence of small scattered vertebral end plate lesions with signal characteristics identical to the adjacent intervertebral discs in several thoracic and lumbar vertebrae. What is the diagnosis? A. Spondylodiscitis with developing vertebral collapse. B. Dannert W. Radiology Review Manual, 7th N. Philadelphia, Pa. Lippincott, Williams, and Wilkins, 2011:57335. 118. E. Scheuermann disease. Scheuermann disease is a spinal disorder named after Dr. Holger Scheuermann, who, in 1921, first described a structural thoracic kyphosis mainly affecting adolescents. Its best-known manifestations are multiple wedge vertebrae and thoracic kyphosis known as Scheuermann kyphosis. Its classic diagnostic criterion was 3 or more consecutive wedged thoracic vertebrae. However, the pathological changes also include disc and end plate lesions, primarily Schmorl node and irregular vertebral end plate. Therefore, the diagnosis of atypical Scheuermann disease was proposed for patients with only 1 or 2 wedged vertebrae and no notable kyphosis but characteristic disc/end plate lesions. Because atypical Scheuermann disease tends to affect the lumbar or thoracolumbar junction region instead of the thoracic spine, it is also called lumbar Scheuermann disease. Lou N. ETAL radiological signs. Signs of Scheuermann disease and low back pain. Retrospective categorization of 188 hospital staff members with 6-year follow-up. Spine. 2014, 39, 2016, 66, 75. 119. A. Fourth. B. Congenital kyphosis. C. Metastatic deposits with early vertebral collapse. D. Vertebral insufficiency fractures. E. Scheuermann's disease. 119. A 76-year-old man with known cerebral atrophy and dementia has been unsteady on his feet for the last 2-3 weeks following a fall down a flight of 3 steps. There is a small external cut. Chapter 1. Test paper. 119. A 76-year-old man with known cerebral atrophy and in the parietal region of the scalp, but he was never brought to the A&E department. A CT brain has been performed to investigate his unsteady gait. It shows a large isodense subdural hemorrhage. All of the following are expected findings on the CT, except A. Fourth ventricle enlargement. B. Lateral ventricle compression. C. Effacement of the cortical sulci. D. Midline shift. E. White matter buckling. 100. Ventricle enlargement, isodense subdural hematoma are a recognized pitfall on CT, which is often difficult to recognize. Indirect signs are hence critical: midline shift, compression of the ipsilateral lateral ventricle, effacement of cerebral sulci, medial displacement of junction of gray and white matter buckling, and dilatation of contralateral lateral ventricle, which is a bad prognostic sign. In case of bilateral collections, the frontal horns lie closer than normal, giving rabbit ear appearance. Adam A. ETAL A.L. Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008:1343-4. Chapter 2. Test Paper 1, Answers. 59. 120, B, bilateral occipital subdural hemorrhage, S. 120, a 1-year-old boy. Boy is brought to the A&E department by his parents with head injury after falling off a sofa. The on-call pediatrician strongly suspects non-accidental injury. Which of the following features on unenhanced CT is most consistent with this? A. Bilateral occipital extradural hemorrhage. B. Bilateral occipital subdural hemorrhage. C. Subarachnoid hemorrhage. D. Parietal skull fracture. E. Bilateral frontal subdural hemorrhage. Chapter 1. Test Paper 1, Questions. 23. Chapter 2, Test Paper 1. SDH and subarachnoid hemorrhage, SAH, are common abusive injuries. Epidural hematoma is much more often accidental. Probably the most common location of inflicted SAH, and SDH diagnosed radiologically is a layer of hypertenuating material adjacent to the falx. Bleeding at the site represents an interhemispheric extraaxial hemorrhage. In this location, it is often difficult, radiologically, to distinguish SAH from SDH, and SDH and SAH may coexist. Lonergan G.J., E.T.A.L. From the archives of the AFIP. Child Abuse, Radiologic Pathologic Correlation. Radiographics. 2003, 23, for 8/11/45. Chapter 2. Test Paper 1, Answers. 60. Chapter 3, Test Paper 2. Questions. Time, 3 hours. 1. An intracardiac mass was incidentally detected during echocardiography in a patient undergoing preoperative assessment. Chest X-ray was nonspecific, showing an enlarged heart.